early on, especially in the 1990s, when anti-HER2 new targeted therapy started to come into the forefront in the metastatic setting, eventually leading its way into the adjuvant setting. Andy, you remember very well that we were bringing in patients weekly for treatment without consideration for how far away they lived, because we felt that we had to do everything we could to save their lives that we were so worried about because of what we had seen previously when we didn't have these therapies. And we went from combining chemotherapies with anti-HER2 new antibodies and weekly, and that started to evolve. We started to look at different schedules. We started to look at when we could perhaps de-escalate. Could you talk to us a little bit about that and what it meant to patients and their families?
Yeah, certainly there are certain regimens that we know can be optimized by more frequent administration. Early in my career, I was involved in the development of weekly paclitaxel, which still remains a standard of care both in the metastatic and early stage setting. And unfortunately, that requires weekly on-site administration. I was involved in one of the first studies of paclitaxel with trastuzumab, a study that we conducted with MD Anderson, and leading to the randomized CALGB 9840 trial, which was the first study to assess whether targeting HER2 in HER2 non-overexpressing breast cancer might be effective. And in that trial, there was no apparent benefit for the administration of trastuzumab in the HER2 negative population, and we didn't even define a group called HER2 low at that moment. I think for patients, one of the dilemmas, Maria, the patients with metastatic disease it's a pleasant dilemma to have, is that when treatment is so effective that patients with metastatic disease have durable, complete remissions who go into stage 4 NED status. We have this wonderful dilemma of, is it okay to stop treatment? Do we have to continue treatment forever and ever and ever? And this is a subject of ongoing research. My personal position on that is the position I would tell my patient I would want for my wife and my daughter and my sister, and that is, if it's not broken, don't fix it. The natural history of metastatic breast cancer, when you leave it alone, tends to be it eventually misbehaves and progresses and causes death. And when you've got a HER2-driven breast cancer, and you've altered that natural history with targeted therapy, until one can prove otherwise, I think we kind of have to strongly consider indefinite therapy for those patients.
Luckily, many of our therapies have been converted to a Q3 week regimen where we can drop the chemotherapy in our stage 4 patients once they've reached their best response, and then continue with anti-HER2 new antibody therapy, whether it's single agent, trastuzumab, who I still see patients from 20 years ago that had liver disease and soft tissue disease and lung mets that are NED stage 4 on single agent trastuzumab, getting it once every 3 weeks. Occasionally, I'll give them a cycle off if they want to go to Europe. But we've evolved, and certainly we have now combination antibody therapy, and with all of that and being able to capture responses where perhaps with original regimens we may lose some responses, we now are keeping patients in the infusion room a lot longer. With combination antibodies, they could be in the infusion room anywhere from 4 to 6 hours just with the antibody therapy. We've started to look at different ways of administering these drugs, especially for these stage 4 patients who are going to be on it for years. And I agree with Andy. I do not mess with, what is not broken. I do continue therapy indefinitely. But, fortunately, in the early setting, we know we have a finite window of treatment.